Thank you. This is a really special day for our citywide grand rounds, and specifically from Mount Sinai Hospital or Sinai Health here in Toronto. These are the Barney Barris rounds, which we have aligned with citywide medical grand rounds, and it's a special yearly rounds with a special speaker that we have got for today. And today you're in for a treat. John Flores will be introducing Sir John Bell. He can tell you, but I'm not sure if might be the first time we have a Sir as speaking at the Barney Barris Day. And John will be giving his bio. I'm just going to give a quick background on Barney Barris, and then we're going to talk about and then I'll give a land acknowledgement as well. Barney Barris was born in 1921 in Toronto. He graduated from the University of Toronto Medical School at the Faculty of Medicine in 1944 and completed his internship soon thereafter. He returned to Toronto in 1951 after completing his internal medicine residency at the University of Minnesota. He returned to Toronto at a different time in the city. And at that time, there were restrictive quotas on Jews for employment at different hospitals. He was actually the first Jewish person hired at the Toronto General Hospital, the first one granted a full-time faculty position within the University Department of Medicine, period. He became the chief of medicine at Mount Sinai Hospital in 1964. Very soon after the Mount Sinai realized its full university affiliation. He was known around Sinai as the doctor's doctor. He was really renowned for his outstanding clinical acumen and exemplary teaching. He served as the chief of medicine until 1977 and continued to practice and teach thereafter. He continued to teach clinical medicine until 1987, well into his retirement years. He has been credited with helping establish the academic foundation of the Sinai Department of Medicine. The Whiteman Barris Academy at the University of Toronto Medical School is named in his honor. He published his memoir, Medicine, My Story, in 2001, where he outlines his life and some of his experiences as a physician in Toronto. It's quite an interesting read. And Barney Barris passed away October 5th, 2009. So since for a long period of time, we've had a special lecture acknowledging Dr. Barris's contributions to Sinai. And over the years, we've had some outstanding speakers, and John can also mention a few of those. I'm going to change gears right now and move to the land acknowledgement for Barney Barris lecture the Barney Barris Lecture Day. I'd like to begin with an acknowledgement of the land on which we work, study, and live. Here in Toronto, which is where we are broadcasting from, we recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. So, changing gears again, I'm going to hand off the baton to John Flores to introduce Sir John Bell. And just before you're asking, full disclosure, John and I are completely not related. There is so there is no requirement for a declaration of a conflict of interest.
Thank you, Hyman. Welcome all to Citywide Medical Grand Rounds. So John Bell is Regius Professor of Medicine at Oxford University. He is only the second Canadian to hold this position. He has served as president of the UK Academy of Medical Sciences from 2006 to 2011 and chaired the Office for the Strategic Coordination of Health Research until 2017. A native of Edmonton, John pursued undergraduate studies at the University of Alberta before receiving a Rhodes Scholarship to Oxford. There, he transitioned to undergraduate and postdoctoral training in medicine, followed by a postdoctoral fellowship at Stanford. His research interests are in the area of autoimmune disease, immunology, and genetics, where he has contributed to the understanding of immune activation in a range of autoimmune diseases. In 1993, he founded the Wellcome Trust Center for Human Genetics, one of the world's leading centers for complex trait common genetic diseases. He subsequently led the development of one of the largest centers for biomedical research in Europe at the Oxford campus. In 2001, he was appointed non-executive director of Roche, and in 2008, he joined the Gates Foundation Global Health Advisory Board, which he has chaired since 2012. He is also chair of the Rhodes Trust. In December 2011, Sir John was appointed one of 2 life science champions by the Prime Minister of Great Britain. He was instrumental in creating Genomics England and the UK Biobank, and sits on the board of Genomics England Limited and chairs its Scientific Advisor Committee. In 2015, he was appointed Knight Grand Cross of the Order of the British Empire for services to medicine, medical research, and the life sciences industry. In August 2017, he published the UK Life Sciences Industrial Strategy and has co-developed in collaboration with industry, academia, charity, and research organizations a follow-up report in 2021 called the Life Sciences Vision for the UK. Recently, he has also taken responsibility for Our Future Health, the United Kingdom's largest cohort initiative where he chairs the board. Sir John has held prominent roles during the COVID epidemic, enabling the development of testing platforms, helping to initiate the PCR program nationally, as well as helping to manage the relationship between AstraZeneca and Oxford vaccine company that produced the Oxford AZ vaccine. He was appointed by King Charles Companion of Honor in 2023 for services to medicine, medical research, the life science industry, and public health. For decades, Sir John has advised our federal and provincial governments, the CHR, and the Alberta Health Heritage Fund. For these and other accomplishments, in 2016, he was awarded an honorary degree by the University of Toronto. During the pandemic, you would have seen him on television informing our national COVID and vaccine strategies. Throughout his career, Sir John has been a visionary, seeking to improve population health and healthcare systems by integrating advances in fundamental science into clinical care. It is therefore fitting that his 2024 Barris Lecture is entitled Changing the Paradigm for Healthcare Systems. I'd like to welcome you personally to Toronto, John, but circumstances do not permit that, but thank you for joining us from Oxford.
Great, John. Thanks very much. Great. Well, look, thanks very much for having me. It's a real honor to be able to present this Barnett Barris Lecture. Barnett Barris was obviously a very distinguished member of the faculty in Toronto and a key pioneer at the Mount Sinai Hospital. And it's a real pleasure to talk about something which I think he would have been interested in, which is really core to where we go with our current healthcare systems. And that's really what I'd like to talk about today is what do we do next with healthcare systems, given the fact that most healthcare programs in developed economies, at least, are becoming increasingly unsustainable. And so the real question is, what do we do next to be able to maintain them and for people to continue to get the maximum benefit out of them? So we've had a really great run over the past 50 years in biomedicine and had a huge impact on life expectancy with a major set of outcomes. Some of them listed here: reduction of cardiovascular mortality by 70%. We've got drugs for chronic viral infections, vaccines for a whole range of childhood, but also a lot of adult diseases. We're now beginning to cure cancer with immune therapies, multiple drugs for inflammatory disease. We're just seeing the first drugs for things like dementia and obesity. huge range of developing tech in imaging. We've sequenced the genome literally millions of times. And globally, we've extended life expectancy by about 19 years. That's a remarkable achievement. And I think
John, I think we have to interrupt. I don't think your slides are sharing. They disappeared.
Right.
Can we help with that? Can we get the slides back up? Sorry to interrupt, but
Yeah, that's all right.
am I correct that the slides have disappeared? Yeah.
We'll have to recycle this, John, I think. So that doesn't look like, it looks like I'm not on, well, I am on.
On the call, yes, what do you need? Would you like to see the slides?
I can't see the slides.
Thank you.
They just popped out.
There we are.
Here we go. And then- Sorry, get this thing down. Yeah. Oops, one, two, and then-
I believe it was the one at the top last time that says use slideshow.
Where's it gone? No.
If you try the top ribbon, I think use slideshow got you there last time. Okay, so we do see slides.
Sorry, there we go. I mean, we don't. No, good. We're good.
Can you see that, John?
Yes, thank you.
Good, super, thanks. This is the first class, yeah, thanks. Great. Well, look, let me just skip through this briefly, but I was talking about the great success that the medical system that we've had since 1970 has had on medicine, but particularly in extending life expectancy, which is, I think, one of the great achievements of the modern world, and probably more important than putting a man on the moon, for example. And you can see the impact on life expectancy in this demographic slide, and you can see how it has dramatically improved all the way through 2015. And that's been a huge achievement delivered by many of the great innovations I showed on the previous slide. Right. Sorry, guys, that's not working. It's not advancing. Sorry, that slides are not advancing to this. So let's see if we can get them.
Why are they not advancing? Yeah, so just
Okay, so
click on the arrow rather than.
yeah, okay, yep, good. So what's happened though is, I think, and we would all recognize that, those of you who practice medicine will recognize, is that the pattern of disease has now fundamentally changed, because although we've delivered an extended life expectancy, our ability to deliver an extended healthy life expectancy has been substantially limited. And in fact, there are a whole range of diseases which have become prominent now, which existed in the 1970s, but have become the dominant cause of challenges for the healthcare system. So as John Flores mentioned, we thought very hard about this when we were revising our life sciences vision in 2021, and we listed the set of diseases that were having the biggest impact on health and healthcare systems in the UK, and indeed globally. And you can see that these are the big chronic diseases that occur in later life, late middle age and to the elderly population. And they're ones where, in fact, the healthcare system has perhaps spent less focus on these than in many other diseases where it's been able to lean in a substantial way. So in the UK, for example, we don't really have credible healthcare provision in areas like dementia, obesity, mental health. There's very little really active prevention going on, and there's no focus on the wider aging phenomena. And this is it's a phenomena which is driven by the exposure throughout life to a whole range of risk factors, which creates this sort of miasma risk factors that people are exposed to. And I think what we've now come to realize is that although we've got a taxonomy of diseases, depending on which organ system gets hit first, the reality is we spend 80% of the natural history of those diseases are spent in pre-symptomatic phase. So by the time you get to 30 or 40 or 50, you're starting to be exposed to a wide range of risk factors, some of them listed there, which are crucial in the pathogenesis of the major diseases at the end. And there's an interesting question about whether these are distinct disorders or whether the organ system that fails first gives you the diagnosis, and then you end up going to see the ologist that's associated with either the heart or the kidneys or the brain or the pancreas. So this problem of massive increase of chronic disease is starting now to have quite a profound impact on lots of the things that we do. And this is a good example of the UK data on people in the workforce who are no longer in the workforce because they're suffering from these chronic diseases. Now, this had a real bounce during COVID, but it hasn't gone away post-COVID. And as you can see, the list of diseases I showed you on a couple of slides before is the same list that produces this particular problem. And at the moment, we're talking about hundreds of thousands of people who are out of the workforce simply because of chronic disease. And that, of course, has quite profound impacts on economic growth, on productivity, and the likes. And the list of diseases, of course, obviously, diabetes, long COVID, mental health, heart and blood pressure problems, chronic back pain, often associated with obesity and progressive illnesses. So this has turned out to be quite a serious societal problem that lives outside of the conventional thinking in healthcare systems. So one of the interesting things which has been pointed out, and this is a slide that comes from Clive Meanwell, is that what's happened is that not only the profession, but the pharmaceutical industry has shifted away from looking at major population health problems to being ever more focused on what some would call precision medicine. And that is the focus on diseases where pathogenesis is probably much better understood, and targeted medicines can yield actually quite significant profits for these companies. So you can see in the table on the left that the revenue from the top 10 drugs has changed actually quite dramatically since 2020. And that what's been interesting is that if you look at the revenue that's generated from the top 10 drugs, it's actually gone up. But the population that's served by the top 10 drugs has fallen dramatically. And of course, if you take those two coefficients, you find that the product of those two things means that there's been a 16-fold change in the benefit that we get on a population level of the drugs that are being produced on a capitation basis. So you can see that there has been actually quite a dramatic shift in the focus of the pharmaceutical industry in terms of what they're focusing on, and they've moved away from the big common causes of disease and have left us with lots of very good drugs for very rare diseases, but that is in its own right creating a significant problem. And that's illustrated again on this slide, because I think it shows quite clearly that if you look at the size of the balls, the diseases where we're actually developing new assets in development are often ones where the size of the ball is actually quite small, where the big conditions which are impacting populations are ones that don't get an appropriate amount of attention. So I think this phenomenon is really illustrated extremely well with the challenge of conditions like obesity. In the UK, we have very limited obesity services in our healthcare system. And that's despite the fact that 26% of the adult population in the UK have BMIs more than 30. I think there's quite a bit of evidence that the presence of obesity in a population has a dramatic effect on productivity and GDP growth. In the UK, we reckon that it's sitting at about somewhere between 3 and 10% of GDP is lost because of obesity. It's a major source of comorbidity. It's largely unaddressed by the current health system. And in fact, there's really limited capacity of the health system to deal with what has been increasingly a major disease, a major common disease. And that's illustrated by this paper, which was published in The Lancet 2 years ago. And it's got a whole, you don't have to read all these diseases, but this is basically a textbook of medicine. And you can see that the impact of obesity on the incidence of many of these diseases is quite dramatic. The dark red ones are diseases where the impact is very large, but even the lighter shaded diseases, obesity has a significant incidence. So I have a significant contribution to their incidence. So this is a really good illustration of how impactful these disorders are in terms of producing a range of comorbidities. And that's shown even more strikingly in this diagram, which compares UK Biobank data and the Finnish cohort data that shows the likelihood of having a second disease if you either have a healthy weight, which is in blue, or you're obese, depending on age, going from left to right. And you can see that the likelihood of having a second, a third, and a fourth disease goes up absolutely dramatically if you've got an underlying obesity problem. So this is the problem that I think we're all encountering in clinical practice, and that is this problem of multi or comorbidities that increase dramatically in later life to the extent we end up with a very large set of the population with multiple chronic diseases. And this is the factor that's really killing the current healthcare system. And it's illustrated really well in this diagram, and that is if you look at the likelihood of having 1, 2, 3, or 4 or more diagnoses as you age beyond age 55, you can see by the time you get to age 85, virtually the whole population has at least one chronic long-term condition. But there's also a very significant number of people with 2, 3, and 4 chronic conditions. And this is the new form of disease, which is now crippling healthcare systems and making them increasingly unsustainable. So our current constraints, at least in this health system, and looking at the charts I'll show you in a minute, Canada doesn't look to be too far behind. This shifting demography has made our 1950s model of healthcare, which is really hospital-based management of acute episodes in late-stage disease, rather outmoded. The population health burden, the diseases I've mentioned, the treatment of disease in late stage, as well as a failure of implementation of technology that could help reduce the load, a poor work environment, low and falling productivity, and a focus on health economics rather than real economics have all led to the kind of challenges that we've got in healthcare at the moment. So I'll show you some data from the King's Fund, who's done a nice comparison of healthcare systems. We used to think that the NHS got off lightly because we were a cheap and cheerful healthcare system, but still had outcomes which were really impressive. That turns out not to be true, and it also turns out probably not to be true in Canada either, because as you can see, both the UK and Canada are well up in the ranks of in terms of cost per as a percent of GDP of our healthcare systems. And in fact, the UK has moved up dramatically to the left over the last 10 years. Canada's not very far behind, and we run much more healthcare systems than they do in places like Spain and Japan. So this is not a cheap way to run a healthcare system. And if you look at those changes in public spending, there's been really a dramatic increase in those costs over the past 10 or 15 years, with a dramatic bump that occurred in COVID, but hasn't gone away and continues to go up quite dramatically. So we're spending more and more on health. In the UK, we spend 44% of our total government spend is spent on the healthcare system, leaving only about half of our government spend for all the other things we need to do in society. So this is clearly not sustainable. But the worst bit of this, of course, is that we're also not doing very well on outcomes. So the UK has higher avoidable mortality and has worse outcomes in almost every disease than every Western country. Canada's sort of in the middle of this pack, sort of approaching the bottom end, but not at the bottom end. I mean, we're very fortunate, of course, that we've got the United States in these figures, because you can always rely on the United States to have the worst outcomes. So we won't ever be last, but we're not in a very proud position with where we are at the moment. So we've got a very expensive healthcare system and pretty bad outcomes. And that's partly due to the fact we haven't addressed the problem that I showed you in the first few slides, and that is the shifting nature of disease that we have to look after. It's also partly related to this problem that we are a technology-averse healthcare system, and you can look at that in a variety of ways. One is in terms of drug spending, we spend a great deal less than most of the other developed economies, of course, except Canada. So you've got the same issue that we do. We're not taking advantage of some of the advances in pharmaceutical development that others have. And we also have a really poor track record in bringing on board a range of technologies, particularly imaging technologies. You can see the data here on MRI and CT scanners. The UK is dramatically the laggard in this space, but you guys are very close behind. So I would say on the whole, neither healthcare system is doing particularly well. And our tech funding for digital has also been lamentably small. In a system that spends 180 billion a year, we're really in single-digit billions spending on digital tools to help us get out of trouble. And if you look at this in the wider set of capital expenditure, you can see the UK compared to peer countries. This is FT data. Capital spending on healthcare is significantly lower than almost all peer countries. We've got fewer beds than almost all peer countries. We've got fewer MRI scanners and fewer CT scanners, as I showed in the previous slide. And the other interesting feature is that this has also been blamed on workforce challenges, not enough doctors. What, of course, has happened is we've dramatically expanded NHS staff over quite a long period of time since 2007. But that actually has had an inverse effect on productivity. As we've increased the staff numbers, our productivity has actually gone down, not up. And you can see the headcount numbers here. They've gone up really quite dramatically. And that's been a serious issue, particularly when you look at productivity, which has fallen away since about 2018 and has fallen quite dramatically in the last few years. And that's not all due to COVID. So I think one of the things that this data shows is that we do have to challenge the current approaches that we're taking to healthcare, because they're clearly not working in the way they should. Productivity is going down, illness is going up, outcomes are terrible, and it's getting dramatically more expensive. So we're actually in a pretty bad spot in the UK. I would argue most single-payer healthcare systems, government-funded, have got the same problems. And that is, I think, in part due to this phenomena that extended our life expectancy so effectively since the 1970s, which is that a healthcare system which is focused largely on hospitals and focusing on acute episodes of care in late-stage symptomatic disease. And as we all know, we spend a heck of a lot of time at the very last few years of life, a lot of healthcare expenditure in that space, and all the acute diseases that precipitate the overcrowding in A&E departments and the filling up of hospital beds is something that we're not really managing very well. And that's the current model of care, which I think ultimately has to change in some format. So you then immediately start to say, well, okay, what could you do about this? And one of the, I think, prevailing views in the UK at the moment is we do have to shift our healthcare systems to the left. We have to focus much more on prevention, early diagnosis, and early therapeutic interventions. We have to focus on reducing multimorbidity, trying to damp down chronic diseases, ideally by treating them very early and flattening the morbidity curve. And we can do that, I think, because we actually now have a set of innovative solutions that we can apply much more effectively, and they include data, but they also include a whole range of other technologies that could be applied to this problem at scale. And we need to deploy these approaches increasingly through a community-based, light touch facilities that will reduce the cost of getting these preventative tools into people. And of course, we also have to review who's doing the work in the healthcare system. So there is another model, which is to think much earlier in the natural history diseases when people are very asymptomatic at a very early stage of disease, when we can both predict risk, screen for health problems early, diagnose diseases based on those risk profiles much earlier, and intervene in those disorders much earlier. And we know, based on a number of really clear examples, that these types of interventions can have a profound effect on the natural history of most of those chronic diseases that are causing the problems that we now see in the healthcare system. So this is a quote from Andrew Scott's recent book on longevity, and that comes from W.H. Auden, surprisingly, and that is, health is a natural state to which medicine contributes nothing. So that's probably an overstatement of the current position, but what is true is the expansion of the physician numbers is actually reducing productivity. Doctors have been historically focused on late-stage symptomatic disease, and shifting these patterns of the way we run our healthcare systems has certainly in this country been disabled by conservatism in the medical profession, who don't really want to do anything different than what they've always done. And many of the problems we currently have in the NHS in the UK are due to the fact that the medical profession itself has not been as flexible as it could be. So if you get to a world where you start to think of predicting risk, preventing disease, diagnosing it early, and treating it early, there are a whole range of new interventions that allow us to shift to the left in a way that we've not previously been able to do. So in fairness, this model of care hasn't really shifted because there haven't been options available. But now, with the application of genetics to polygenic risk scores, a range of protein biomarkers that can predict disease much more accurately, the wider use of digital records, but particularly AI applied to those records, and the use of causal inference to predict disease before it occurs, aligned with a whole set of early diagnostic capabilities, including circulating tumor DNA, better and more effective imaging, high-risk population screening, and then a whole set of therapeutic interventions, which again are relatively new, in addition to those that we've used historically to control LDL cholesterol, blood pressure. We now have drugs for obesity. We have long-acting injectables. We can treat cancer at its earliest stage with immunotherapies. And there's a whole range of inflammatory therapeutics that can be used highly effectively at an early stage. So when we sat and thought about this problem of what do we do with our healthcare system and how do we get it to work much more effectively by preventing disease, diagnosing disease before people become symptomatic, and treating people at that early stage, we sat down with most of the major components of our healthcare system, including the NHS, but also the MRC, the Wellcome Trust, and others, as well as the life sciences industry in the UK, which, as you know, is thriving. And we decided that what we needed to do was create a sandbox to test and evaluate these various interventions as a sort of model system for a shift, an entire shift in the way we deliver healthcare. And so we created this entity, which John has alluded to, called Our Future Health. And that project was really set out to deal with this increasing burden of chronic diseases, which we've talked about: diabetes, dementia, cardiovascular disease, obesity, and to deal with this issue that ill health is not only causing challenges for hospitals and healthcare systems, it's now creating a massive drag on national economies. And that's coming again from the same set of diseases, and we need to get on top of those in some sensible way. Even in working age populations, 36% of people have long-term health conditions. And as you saw from my tables earlier, many of them have got multiple comorbidities. And of course, there is also the additional complexity of health inequalities driving higher levels of ill health in ethnic groups and people with from poor socioeconomic backgrounds. So these are the challenges that we were trying to confront with Our Future Health. You can see that life expectancy has been steaming along until the last few years, where it's flattened and is actually now in some jurisdictions beginning to fall. And you can see that on the right-hand table. So we're not winning this fight. We've got an old model of healthcare, and we do need to shift it. And so the idea of Our Future Health was to build a program that allowed us to test and evaluate new approaches to healthcare using some of the new tools that are rapidly becoming available from the industry, but also from the way we treat and manage patients, from genetics, but also from the way we try and prevent disease with health screening programs on a wider level. And part of this, of course, is trying to estimate personal disease risk with genetic and non-genetic information. As you know, integrated risk scores look rather interesting in this space, particularly for the big chronic diseases, and we want to test and evaluate in those cohorts. But then when we establish cohorts, sub-cohorts of this large population, we're intending to try and use those to actually ask individual questions about whether there are things we can do to modify people's risk and reduce the morbidity that is usually associated with most of these diseases. So in order to do this, our intention was to build a cohort which was big enough to do this across multiple diseases. So we set out, well, we established the plan before COVID, but we set out to build this asset about 18 months ago. And we brought together a whole set of collaborators, starting with the NHS, but also extending into most of the big charities in the UK, but also 17 major pharma and medtech companies that are participating in the program. And from there, we've been able to raise the money to run this program, we hope, out to a total of 5 million participants. The idea, of course, is to be able to use that 5 million people to test and evaluate more effective approaches for prevention, more effective approaches for early detection, and for early treatment of diseases. And of course, in order to do that, we have to take a set of biosamples, which we store, but we also do full genetic typing using a large chip. So this is the genetic analysis. We have a custom array of 700,000 genetic variants that we've developed with colleagues on the bottom panel. It's optimized for the UK population. We're using it to define risks in the population. And we're able to do this at scale. And because we're doing it at scale, it turns out to be a remarkably inexpensive bit of the overall program. So it gives us another dimension to try and test and evaluate the role of genetics in identifying risk. So we're doing a lot of things now. We're doing baseline questionnaires, biological samples, doing consent. We're currently moving into the genotype array. We'll have 600,000 people type by the summer, including imputation. We're doing cognitive function wearables. We're moving to expand those in the near future. And then we will use the validation of this in some cohorts to test and evaluate new ways so we can intervene in this population. And the recruitment fit to this is to set up a recruitment strategy that will allow us to get to 5 million people. So we are now actively recruiting around 80 appointment venues around the country. We're using community-based, entirely community-based. We don't use any hospitals. We don't use any GPs. These are community pharmacies like Boots. They're pop-up labs in shopping centers. They're mobile trailers, as you can see in this slide, which work incredibly effectively. And these are hugely effective. And we're now recruiting about 80,000 people a month into this program. And this shows the cumulative rate of participants recruited into the study, all the way from consent through to sample collection in these sites. We've now got 1,800,000 registered participants, and we've got well over 700,000 people who've given us samples that we can use in our biological studies. And compared to other cohort programs, this has taken off much faster than the others. We're recruiting dramatically faster than UK Biobank, but also dramatically faster than the American equivalent, which was all of us, and all the other relevant cohorts. The yellow dotted line is the trajectory that we're on. And this is just a really good illustration of where we've gotten to, showing a dot. Each one of these dots is a new person recruited in the UK. And you can see over time, these volunteers have expanded dramatically, particularly in the areas where we've leaned into having these recruitment centers and the blood sampling sites. And you can see that we've got people pretty much all over the UK. We haven't started in earnest in Scotland, Ireland, or Wales, but even then you can see that there are people in the far reaches of Scotland who managed to sign up for the program. And that was the first iteration. We're now, as I say, up to 1.8 million people. And we've made a huge effort because previous cohorts have failed to take in ethnic diversity and socioeconomic class. So we've leaned into the idea that we can actually get a much more representative sample, which is obviously crucially important, particularly from some of these major chronic diseases, where inequalities of health is a really dominant feature in these disorders. So we've tried to overweight the availability of sampling sites and recruitment in places which are ethnically diverse. And you can see here, this is the distribution of ethnicities of full participants on the left-hand side, and the ethnicities that you see from the census on the right-hand side. So we're not quite at a representative sample, but we're doing an awful lot better than almost anybody else has done before. So we think this is going to be a pretty interesting and pretty representative cohort as we finish it off. Now, the bad news is that when we recruit these people, we, of course, measure the standard things in the clinic: obesity, hypertension, and high cholesterol. And this has not gone very well, because we start recruiting people at the age of 18, and we take this all the way through to whatever level we can get over, people. We've got a few people over 100 who've signed up. But the bad news is that if you do a sample in this population and you look at obesity, you find that actually we've got, in our sample, we've got about 20% of the population of BMIs over 30. Hypertension, somewhere between 25 and 35% of people have uncontrolled blood pressure, and about 50 to 60% have cholesterol greater than 5 millimoles per liter. So the UK has ended up with a pretty unhealthy population, which probably explains some of the challenges that we've had for the onset of major chronic disease in later life. And I think when you look properly and systematically across populations, I suspect this is probably not too dissimilar across most developed economies. I mentioned briefly about the economics of health. We know about the rising cost of obesity in the UK, the impact of chronic disease on productivity and GDP. And we've now engaged the Treasury and the Office of Budget Responsibility, and we've linked our data up to the ONS employment data so that we can actually track the impact of health on people in the workforce. Can we get people back in the workforce, and what are the factors that make people leave the workforce? So this is something that the government is extremely interested in from this study. And this is the sort of data that actually freaks out the government. This is data from which we did with the Tony Blair Institute and the Frontier Economics, shows the cost of, this is in pounds sterling, the cost of obesity and overweight in our population. And you can see the total costs across, including societal costs, productivity costs, social care. The damage here comes out at a pretty bad number, which is about 100 billion a year, which is a huge amount of money. People complain about the cost of the obesity drugs, but when they look at this, they stop worrying about those numbers for obvious reasons. So there's a whole range of therapies, as I mentioned before. The obesity medicines are obvious, but so are the siRNAs, long-acting. They eliminate compliance issues. Got siRNAs now for PCSK9, angiotensinogen, Lp(a), lots of adult vaccines that we can use at scale. We did a lot of work with the medicines company to develop the RNAis against PCSK9. This is inclisiran. This is a drug which probably will be efficacious across a whole year. A single shot dramatically reduces LDL cholesterol. And that's turned out to be a bit of a gift for this prevention agenda. You can see this is averaged over months. You can see the dramatic effect of inclisiran. This is the Orion 11 study. We've also been involved in some of the larger studies. And you can see that there's really a dramatic impact of these medicines. So we have medicines that actually will help to tackle this in actually a profound way. You will have all seen the SELECT trial of semaglutide, 20% reduction in cardiovascular events using one of the obesity drugs. But it turns out that these drugs appear to have pretty significant effects across many other diseases: stroke, heart disease, obviously, heart failure, chronic renal failure, particularly in diabetes, but also things like fatty liver, and possibly also things like smoking cessation in the legs. So you can see that that's a pretty interesting play. So I think this shows that actually there are ways to start to approach to this problem of how can we get in earlier in disease, how can we predict disease using the new technologies, and how can we intervene in these diseases with a health system which is focused in asymptomatic people early in life, flattening the morbidity curve. And there, one of the crucial issues is that you do need to think about what a cost-effective delivery mechanism for trying to do prevention, early diagnosis, and early therapy at scale is. What is a prevention-focused and early diagnosis and therapy-focused program look like? And around that, with Tony Blair's institute, we developed this concept of one shot, which really takes a lot out of the way we delivered population health interventions during COVID, and that included testing as well as the delivery of vaccines to whole populations. And of course, it turns out that you can do this in the community, provided you have a good digitally enabled system that allows you to identify the people who need interventions. You can call them in digitally, you can send them a message on their phone, and then you can give them interventions in the community with very little intervention